Many of you are with first episode psychosis teams, and you often hear us talk about first episode. And I think you hear us talk about clinical high risk. Carrie and I have been working on this program for about the past 6 years with one of our Akron agencies. They are fully self-sustaining now, which is very exciting. But we worked on the project with them for a number of years. And so we wanted to share information about clinical high risk for psychosis, just sort of as an awareness raising, or if people are interested in learning more about it. So talk a little bit about what is CHRp. That's what it'll be referred to as. How to differentiate it from first episode psychosis, identify common comorbidities with clinical high risk, and what providers can do to recognize if someone might be experiencing symptoms of clinical high risk. So a very brief history of clinical high risk for psychosis. So in the mid to late 90s, the concept of CHRp started out of research in Australia and Europe, and it's more recently, maybe in the past decade, a little bit less, has come over to the United States. And the goal of addressing clinical high risk, recognizing clinical high risk, is more on the prevention side of things, or at delaying a transition to psychosis for those individuals where we can't prevent the course of illness. So clinical high risk for psychosis is often described as like the pre-psychotic phase. They present with potentially prodromal symptoms. They typically are experiencing some kind of distress. And so that's why they end up, through our doors, is because they recognize something is unusual or odd, and they're not sure what's going on with them. They're not recognizing what might be the cause of this. So the early warning signs are really non-specific. I think that's one of the key pieces for clinical high risk. So feel like something's a little not quite right, a little bit of confusion, feel a little anxious or fearful, but not sure why they maybe feel that way. Sometimes verbal communication especially is impacted. So that verbal communication, they're starting to have less interest or pleasure in activities or people. They're not engaging in self-care or hygiene, starting to have some difficulties at work or school. And people are observing that something might be going on with this individual. But again, very non-specific. So, just looking at the whole continuum of schizophrenia, psychosis, you have this sort of pre-morbid phase, which is a lot of things are happening with that individual, but hindsight's 2020. We don't have a crystal ball. We can't, see what the future is going to hold if they present with these non-specific symptoms. Then you have this prodromal phase where they're starting to experience some symptoms of psychosis, but they're brief. They might be intermittent. They might be sub-threshold. And then you move into the psychotic phase. So what we're really talking about is that sort of end of the pre-morbid into that prodrome phase. And, targeting, our work with the Best Center, oftentimes we target the whole continuum, all the way through stability and recovery. But that sweet spot is really that childhood to adolescence, young adulthood is where we see some of these clinical high risk for psychosis symptoms starting to appear. So how do we think about CHRp versus early psychosis? So clinical high risk, this individual recognizes that changes or odd experiences are occurring. They have some insight that remains relatively stable, and they can really appreciate that these altered perceptions about the world around them are not real. They have some ambivalence, or they're questioning the reality of experiences, which is key for this group of people. And you're able to induce doubt. So, oftentimes in CBTp, we talk about alternative explanations. They're able to entertain that idea that, okay, so maybe it's not that. I can see that it could be, it very well could be this other cause, or this could be a reliable explanation. And the experiences are bothersome, and they're starting to impact their day-to-day lives, right? So with first episode, these clear symptoms of psychosis develop. And one of the how I think of it with comparing CHRp to first episode is with CHRp, they're not quite sure. They know something odd is happening. They're not convinced that it's caused by something outside of most people's realm of experiences. But with first episode, they have 100% conviction that their experience is real. They're not, it's very difficult to get them to be open to alternative explanations. They truly believe what their experience is it's indisputably true. And these symptoms are starting to really interfere with their day-to-day life. So does that make sense to everybody, sort of that delineation? Somebody with CHRp has some insight. They recognize changes occurring, and they don't have that 100% conviction that their experiences are true or real. Okay. So CHRP syndromes are kind of, we think of it in looking at 3 ways for, about meeting criteria for a CHRP syndrome. So first, we'll talk about attenuated positive symptom psychosis risk syndrome, APS. So I think this accounts for about 85% of individuals at CHRP, clinical high risk. So they have some unusual thought content or suspiciousness. They might be getting a little grandiose, having these abnormalities in the perception of the world around them, and some communication disturbances. So some combination of these symptoms that are occurring at least once a week over the past month. So pretty short duration, not constant, not totally consistent. They've gotten worse over the past year, and the person's starting to feel some level of distress. And so at least one symptom is present in this attenuated or subthreshold form. So the way to think about this is, in the DSM-5, there's this other specified schizophrenia spectrum and other psychotic disorder. There's a specifier for attenuated psychosis syndrome. And what this looks at is that it's characterized by psychotic-like symptoms that are below the threshold for full psychosis. So the symptoms might be less severe, they might be more transient, so again, not constant, and they maintain a pretty solid degree of insight. So this is in the DSM-5 condition for further study. The second that accounts, I think, for about 10% of CHRP cases is the brief intermittent psychotic symptoms psychosis risk syndrome, BIPS. So the keys here are that they're brief and they're intermittent. So one of those 5 core symptoms that we talked about, the unusual thought content, grandiosity, so on, has reached a psychotic intensity, but they're not fully disorganized. The individual, they're not dangerous to the symptoms, aren't dangerous to the individual, not putting them in dangerous spaces. Also, they are not constant. And again, the person maintains some relative insight around this, and they recognize that there's something distressing them. The symptom, importantly, does not last more than 1 hour a day for 4 days over a week for a 1-month period. This is really hard for individuals to be able to report back how often they're having this experience, right? If somebody asked me so that I could break down, it would be really, really difficult. And I think I just want to highlight here, this is where family support people, the people around them, really come into play when there's because they're able to report how often or how frequently these things are occurring. So this just started, the BIPS started over the last 3 months. And it's just short periods, several minutes per day. All right. And then the third syndrome that can kind of make somebody qualify for being identified at clinical high risk is genetic risk and deterioration psychosis risk syndrome, or GERD. So the genetic risk for schizophrenia spectrum disorder and a recent functional decline. So they have to make both sides of that coin. The decline, even though we don't really use GAF, but it's more than 30% drop in their global assessment of functioning. And what we know is that psychosis risk is 1 to 3% in the population that has no immediate relatives with psychosis. An individual is at higher risk, 45% risk with 2 parents that experience psychosis, 13% if it's 1 parent, and 10% with a sibling who has a condition. So an individual with a first-degree relative of any type of psychotic illness increases their risk. They've had a functional decline, which could be also inclusive of meeting criteria for schizotypal personality disorder. So again, some of these symptoms not really being clear, understanding that something's happening, but again, more subthreshold. Conversion rates to psychosis. So this is where we really have an opportunity, and what the CHRp team target that we worked with in Akron really targeted to prevent this conversion or transition to psychosis. So, we look for a combination of these subclinical symptoms and these risk factors. Current literature, although it's ever changing, but the most current literature says that at 1 year, about 15% of individuals have developed first episode psychosis. 2 years, it increases to 20%. And at 4 years, 25 to 30% of those who are identified at clinical high risk are now transitioning or converting to first episode psychosis. So really an opportunity here to do a lot of good work to try to prevent that conversion to psychosis, or to mediate that transition. If there's a first episode team, or they're working with a team of separate individuals, not necessarily a CHRp or FEP team, but who are aware of what to look for, how to work with these folks. It can really, decrease the duration of untreated psychosis. It can offer opportunities for the individual to, have less trouble at school, at home, when we're intervening early. So as is apparent with CHRp, because symptoms are so non-specific early on, it's not surprising that there are often a lot of comorbidities or comorbid diagnoses when somebody is at clinical high risk. So at baseline, more than 70% of individuals at clinical or high risk had at least one diagnosable disorder. The most common diagnoses are anxiety, depression, and social phobia. And I think in our experiences with the Akron agency, those were very, very common. A lot of social issues, some OCD also is sort of fourth in line that you'll see pretty typically. And many individuals that are at clinical high risk have 2 to 3 comorbid diagnoses in these early stages. So when you see, they're functioning day to day, starting to become impaired, they're starting to have some of these anxieties. They might also have some depression. And part of that is because they're recognizing something odd is occurring, something that they can't really explain or make sense of is occurring. And this is causing them some distress before they have, full-blown symptoms of psychosis. So only about 20% of the CHRp group don't have a comorbid diagnosis. So much more likely that they will have this diagnosis. Interestingly, comorbidity is independent of the clinical outcome, and this is outside of cannabis use. When we throw in cannabis into the mix, it really does change things. But this is, comorbidity is independent of clinical outcome and how things will look for that individual. But at baseline, cannabis misuse differentiates those who convert to psychosis and those who do not convert, so making it more likely of a conversion. So, just to highlight, you can see the blue, almost half of the circle, major depressive disorder. The red and the green are your generalized anxiety and social phobia, but also, fourth in line, just like we saw with the team, OCD, see some bipolar panic disorder, PTSD, and a bit of, those individuals. And in this study, only 11% had no diagnosis rather than the 20%. So with clinical high risk, it is a challenge. Obviously, to accurately identify these folks. And also then our work is to prevent or delay the onset or mediate the onset for those who do develop psychosis. But it's also an opportunity, because we really do have an opportunity to reduce the transition for those who are at risk of psychosis, or to make that transition more successful by offering them wraparound services. So things that we can do as service providers, prevention is powerful. So individuals who access CHRp services, compared to those who are only, they wait until they have a full-blown first episode. So if we can catch somebody early and intervene and offer individuals who are at clinical high risk some services, they are less likely to require admission following the onset of psychosis, a psychiatric admission. They spend fewer days in the hospital. They have a lower frequency of admission, so less kind of these repetitious visits to the hospital, and amongst other things. So really important that we address this. Obviously, other things that we can do are, being aware of clinical high risk for psychosis and the impact it can have on the individuals and their family systems. Screening for early psychosis, there are lots of tools out there. One of the classics is the PRIME screen. But something to think about is that if we're screening, knowing what to do with that individual next. But it can increase the accuracy of assessments, doing this initial screening We can find people not in services, especially if, you know, pediatricians, primary care doctors, schools are doing some of the screening. There's a gold standard assessment. So a full-blown assessment, it's, you know, I think it takes about 2 hours to administer. It's called the SIPS, the structured interview for prodromal symptoms, but it does require specialized training to be able to administer the SIPS. But again, once the positive symptoms that are identified, it's 5 domains on the SIPS, looking at positive symptoms of psychosis. So these symptoms really do map on to, you know, the classic symptoms of first episode. We know from the literature that some targeted psychosocial interventions really can reduce the frequency of conversion. The basic principles that are out there now about CHRP care are building rapport, which we all do with all of our individuals anyway, target the client's identified priorities, and using our existing skill set to kind of navigate this with folks. And international reviews are really starting to emphasize that treatment needs to be tailored, therapy needs to be tailored to that individual. Assessments need to be completed, offering case or care management, and then really involving the people around them, so family and natural supports. So I think, you know, for me, the biggest takeaway is if you're thinking about clinical high risk for psychosis, those individuals maintain a pretty good degree of insight into what's happening, or awareness that they are experiencing these, you know, odd perceptions in their world, and they don't have 100% conviction that their experiences are reality, so that they're more easily open to alternative explanations. So that for me is how I think about CHRP compared to first episode.